Hello, my name is Elysa Bond, and I am a cancer genetic counselor at Rush University Medical Center. My presentation is titled Disclosure of Genetic Risk to Dating Partners Among Young Adults with von Hippel-Lindau Disease. When do you share? I don't have anything to disclose. Dating is considered a key milestone of emerging in young adulthood, and genetic risk poses unique challenges with risk to one's personal health as well as risk to potential children. The literature demonstrates that affected or at-risk individuals often perceive their genetic status as negatively impacting their desirability. So they may be motivated to disclose their diagnosis to a dating partner for support, but they may not share due to a fear of rejection. And consequently, individuals experience distress concerning if, when, what, and how to disclose. Previous research concerning genetic risk in dating has predominantly focused on young women with hereditary breast and ovarian cancer syndrome, or HBOC, and their family planning. These young women express a sense of urgency to find a partner and to have children prior to prophylactic surgery or future cancer treatment. They perceive themselves as having decreased desirability, with a particular emphasis on physical attractiveness and sexual relationships. Overall, young women with HBOC report that they are worried about disclosure to dating partners, how to approach this, especially in terms of timing and what to say, and how their partner might react. We've learned a lot from the HBOC literature, but there is a scarcity of research investigating the lived experience of young adults with hereditary tumor predisposition syndromes such as von Hippel-Lindau disease, or VHL. While VHL and HBOC may both be put in the category of hereditary cancer syndromes, there are many differences and possible reasons why current evidence from the HBOC literature may not be immediately translatable. The high multi-organ tumor risk of VHL is very different from the cancer risks of HBOC. Though most manifestations of VHL are benign, they can have significant impact from loss of vision to loss of mobility. The risk of renal cell carcinoma is a significant cause of mortality, as are hemangioblastomas of the central nervous system. Because VHL can affect many parts of the body, there's a lot of variability in presentation, which means unique unpredictability. Onset in childhood and young adulthood, often prior to marriage, may impact dating relationships differently than HBOC. Men and women are affected more similarly by VHL, whereas women may be more significantly impacted by HBOC. Consequently, less attention has been paid to young men's needs in this context. Individuals with VHL undergo complex screening to monitor tumor growth, but there are not preventive options comparable to a risk-reducing mastectomy or oophorectomy, so there might not be the same sense of dating urgency ahead of surgery. Lastly, VHL is really unknown to most people. There's more familiarity with BRCA, and at the very least, people are much more familiar with breast cancer. So to address the need for research in this area, the objective of this study was to investigate the challenges in navigating dating relationships faced by young adults with VHL in order to assess and facilitate adaptation during young adulthood, and specifically to understand attitudes towards dating and motivations and barriers to disclosure to a dating partner. We recruited young adults for qualitative interviews through the University of Michigan Rogel Cancer Center via Genetics Research Registry, as well as through the VHL Alliance, a national support organization. 70 individuals completed our screening survey that determined if they met our two study requirements, that they were 18 to 35 years old and they had a diagnosis of VHL. All those who indicated interest in participating in a phone interview about dating experiences were invited to interview, and 26 ultimately completed an interview. Our semi-structured interview guide was initially informed by previous research concerning disclosure to peers and to romantic partners, and we received feedback from a young adult with VHL. Interviews were recorded and transcribed, with most around the average of about 47 minutes. The interview guide contained questions pertaining to the broader lived experience of VHL that we felt could be important context, and specifically regarding dating and disclosure. For this presentation, I'll be focusing on some of the data related to participants' perception of the impact of VHL on dating, their experiences disclosing their diagnosis to dating partners, and experienced and desired support for disclosure. Transcripts were coded using a primarily deductive approach to determine how themes compared to the literature concerning other genetic conditions such as HBOC. Of our 26 participants, 65% were female, 38% were de novo cases, and that's compared to a de novo rate of about 20%. The majority of participants were white, and the majority had at least a 4-year college degree. Participants ranged in age from 21 to 35, with an average age of about 27. Age at diagnosis, which is shown here in blue, ranged from 6 to 29, averaging around age 16. All participants had experienced some manifestation of VHL, but the level of impact varied greatly, from very minimal impact to visible physical disability. From a romantic perspective, current relationship status also varied. 27% were single, 46% were in a relationship, and 27% were married or engaged. The majority of participants indicated that they had only had partners of the opposite sex. 2 men identified as gay, and 1 woman identified as bisexual. Most participants shared that they do feel VHL makes them less desirable as a potential partner, matching previous research. Many fear rejection after disclosure because of a general sense that they have baggage, or as this woman describes, because of the perception that a partner will not want to or will not be able to handle health risks. She said, "Part of me was very scared that he would be like, this is too much. I don't want to commit myself to a person who potentially could have all of these bad things happen to their health." Some said they fear rejection because a partner might not accept reproductive risks or their decision not to have biological children, which is often cited as especially difficult to share. The sense of undesirability is heightened following experienced rejection, making future disclosure even more difficult. This 30-year-old said of a negative experience with an ex-boyfriend, "I feel unlovable because of it, because if I was with someone for that long and they couldn't love and support me with it, then how could I expect anyone else to? Really made me wonder if people could deal with someone who had this sickness." There's also a sense from some that while rejection may not happen immediately after disclosure, VHL may negatively impact a relationship over time and may later end the relationship. A few discussed concern that their diagnosis would burden a romantic partner and wondered if being in a long-term relationship was selfish. This was particularly true for those who saw a parent become a caretaker for their affected parent and saw how that impacted their relationship. What was especially unique compared to HBOC is that our participants said that VHL often sounds scarier than it is and can be really overwhelming for other people to learn about, which exacerbates the fear of rejection. Many said that other people have never heard of VHL and tend to exaggerate the seriousness. This man shared, "It can really, really upset people. I think it can really freak people out because all they'll think is, oh, it can never be cured. These tumors will always come back." Because of this, many participants expressed difficulty in deciding what to share with partners and how to explain VHL in order to avoid rejection. A few participants said that they wanted more support in this regard, such as this individual who said, "I guess I'd like to learn how to make it less scary. It hasn't scared off anybody that I know, but it is a lot, and I would want to be able to present it in the right way, not to make it sound like it's the end of the world." Many participants discussed downplaying risk and the impact of VHL in order to combat this threat of rejection, as well as other unwanted reactions, employing strategies such as emphasizing the word benign and avoiding the word cancer, or omitting details such as life expectancy, inheritance, or where tumors could arise. This 23-year-old said, "The last thing I want people to do is pity me or think that I'm weak or treat me like I'm sick. I think that's part of that inappropriate response. If I downplay it, you won't think these things." Relatedly, some described how difficult it was to bear the emotional burden of the other person's over-the-top reaction. This participant elaborated, "I've gotten to a good place with it, or I try to, but it scares people. And it's hard because I've worked really hard and I do see a therapist to try to be healthy, but other people haven't. If you have an inappropriate response, I don't want to have to be the recipient of that." So downplaying VHL and disclosure can help avoid that reaction. In contrast to minimizing risk, other participants valued complete disclosure, particularly due to the perception that withholding information is dishonest and unfair to a partner because it could impact their decision to stay in a relationship. Some described how honesty was very important to be completely transparent. This 28-year-old actually described emphasizing the possible severity and some of the scarier sounding statistics. "I didn't want to continue in a relationship with someone who didn't understand how serious this could be, what the long-term implications were. He was making a choice. I didn't want that choice to be sugarcoated in any sort of way." For others, total disclosure was used very intentionally as a litmus test or a vetting process. The possibility of rejection motivated some to share very early on about the reality of VHL in order to determine if a partner would be accepting or to otherwise get rejection out of the way before investing too much time or emotional energy. This woman explained, "I think I felt better to know now if this is going to scare him off than invest more time in this and see if it scares him off later when he really understands how serious it is." Some participants expressed that it can be difficult to experience negative reactions, but it's okay if disclosure is a filtering mechanism. You want to be able to share all of yourself in a relationship. This 30-year-old said simply, it's going to be okay to share it. If it impacts the relationship, then there are better relationships out there. While most participants described at least one negative reaction, participants also described positive impacts after disclosure. A few said that it strengthens relationships because it's seen as a gesture of trust. This 23-year-old said, it's definitely deepened my relationships. I think I have to be more genuine. I think I'm a lot more emotionally healthier now because I discuss it. I think when you're appropriately vulnerable, it can have a positive impact on the relationship. So how can we offer support in this? Overall, participants cited a perceived lack of resources. Despite the fact that this is something that can be challenging, many indicated that this interview was the first significant conversation that they had had with anyone about it. Most said that healthcare providers don't talk about this at all. Conversations are really limited to reproductive risks and inheritance, and appropriate referrals beyond physical health are not being made. This 26-year-old described, I only saw a genetic counselor once. And one of the things is like, well, kid, like I'm 13. What am I going to tell my boyfriend? It's always about these big, serious life things. But what about just dating, casually? There's no way to navigate that. No one was talking about that. And then you just kind of muddle through, and heartbreak after heartbreak, you finally figure it out. Some participants thought that healthcare providers should definitely talk about this, potentially getting young adults thinking about how they might initiate a conversation with a partner. This 27-year-old said, I think it would be something that should be shared with VHL patients, how to talk to a partner about it. Maybe not necessarily coaching on it, but you may want to think about discussing this, or this may be a good jumping off point. One participant went back to a genetic counselor specifically to talk about dating because she was struggling with it. When asked what was helpful about that, she said, I think just reiterating some of the stuff that I kind of already knew, that it's not a death sentence, that people date people that have these things all the time. Just because I have a diagnosis doesn't mean I'm not worthy of the love and the support that I so desire. I feel like a friend is always going to tell you that kind of thing, but I think I needed to hear it from an impartial person. Even if they didn't want to talk to a doctor or genetic counselor about this directly, many thought that it would be really valuable for healthcare providers to ask if their patients are interested in talking to someone else about it. They should point patients towards other resources. This 26-year-old shared, I think just being actively encouraged to seek out, not just go to your scans, but actually talk to someone about this, someone who has therapeutic experience with chronic illness. Even if it's nothing like VHL, but just the mental weight of having something. Seeking out a therapist or a genetic counselor or group therapy with people who actually understand this and can help guide you. That would have saved me so much grief over the years. Some participants expressed a lot of disappointment and even anger that referral to a counselor with experience in chronic illness is not standard practice, and were very frustrated that they hadn't known this was an option sooner. We learned a lot about challenges faced in navigating dating relationships by these young adults. And similar to other genetic conditions such as HBOC, VHL does contribute to a perception of decreased desirability and a fear of rejection. But more surprising was that others' perception of VHL as particularly scary or serious uniquely exacerbates this concern. And this is different from a concern regarding physical desirability. Because of this fear of rejection, participants frequently wrestled with what to share, with differences in the extent of their disclosure, either downplaying VHL or using complete disclosure as a litmus test as they navigated early stages of relationships. Overall, participants expressed that they had mostly muddled through on their own. They wish it had been brought up by healthcare providers and that appropriate referrals had been made or been made sooner. It was definitely not our intent to come away with best practices or any sort of instruction manual for disclosure, because there's many different styles and there's not a right or wrong way to approach this. It's just another very personal decision, which I think is very much in line with the non-directiveness of genetic counseling. Genetic counselors are uniquely positioned to offer desired support in this area and to make patients aware of long-term resources. And while VHL is unique in many ways and certainly distinct from HBOC, I think even if you never see a patient with VHL, these perspectives may be common to many young adults adapting to a genetic diagnosis. I'd like to acknowledge the other talented individuals who contributed to this research, as well as the VHL Alliance, which was really instrumental in making this research possible. I'd also like to thank the Jane Engelberg Memorial Fellowship Student Research Award for helping to fund this project. Thank you.